Good evening, everyone. My name is Adi. I am the webinar lead at Mind the Bleep, and today I'm going to be doing a talk on. It's the first talk in our new Geriatrics series, and it's going to be covering falls, fractures, and mobility. This is going to be the first of a number of talks. Sorry, 1 second. Apologies. So this is going to be the first session in a series of 8 planned talks, and this is going to be the outline of the entire series. So we're starting today with a talk on falls, fractures, and mobility. We're then going to be moving on to a talk on movement disorders in a couple of weeks. Then we're going to be chatting about advanced care planning. There'll then be a talk on dementia and cognitive disorders, which will happen in early September, followed by a talk on geriatric liaison services, which you may be familiar with, but it's a really interesting talk. We'll then be talking about acute medical presentations in geriatrics, which is something that I'm sure we will all be encountering over the course of our careers, regardless of which specialty you're working in. And then lastly, we'll be finishing up the series with a chat on frailty in younger adults, which is something that we're seeing increasingly with advances in medical care. Couple of things just for this event and for the rest of the series as well, just on housekeeping. So it's helpful for us if you register on CareerBook ahead of time. This just gives us an idea of attendance numbers and helps us to just plan our webinars accordingly. At the moment, as CareerBook is still developing some of its services, we are using, as you've all logged on to YouTube now, we're using YouTube, our live page on our YouTube account to actually stream our webinars. So log into that page at the time of the scheduled webinar, as you all have today. Thanks very much. And then at the end, there'll be a QR code on the screen, but the link is also there, mindthebleep.com/webinars, is for you to give us some feedback, which is really helpful for us because it helps us see if the content is being pitched at the appropriate level and if it's useful for you. And also importantly for you, it gets you a certificate which you can add to your portfolios for your teaching logs. So hopefully it's useful for you as well. So an overview of this first talk. By the end of the session, I want you to all be able to identify the multifactorial causes of falls in older adults. The main things I'm going to be covering today are cardiovascular, musculoskeletal, neuropsychiatric, and environmental factors. I then will talk you through how to conduct a thorough assessment of patients presenting with falls, including the key aspects of the history taking and also physical exam components. And I want to help you understand the multidisciplinary team's role in all of this as well. I want you to be able to recognize the red flags in any presentation with falls that require urgent attention, such as head trauma or suspected fractures, and to use appropriate investigations to determine the underlying causes of a fall. Lastly, I'm going to briefly touch on bone health principles, how we assess someone's fracture risk, and how we actually manage this. So why are falls important? Well, we're going to explore exactly what kind of issues a fall might signify. So falls, for most people, wouldn't result in significant injuries. However, the very fact that someone might sustain a fracture, such as a hip fracture from a fall, is a significant marker of frailty. And so really what this indicates to us is it's a symptom of a wider underlying syndrome. Falls are also very expensive to the NHS. This is a slightly old figure now, but it's estimated that it costs the NHS at least £2.3 billion every year. And this is a figure that's only likely to increase as time goes on. So it's important to understand why someone has had a fall, because that helps us guide their care, both acutely and in the longer term as well. In turn, this will reduce the burden of falls on the system, and most importantly, it results in better patient outcomes. This is a really important point that I'm going to hammer home a few times over the course of this talk. Falls in the elderly are very commonly multifactorial. And it's important to highlight this before I talk about all the causes of falls. We're going to go through things in a systematic basis, but the truth is that the majority of falls in this demographic in older patients are contributed to by a variety of factors. So just bear that in mind as we're going through the slides. So why do people fall? Well, let's talk through one of the more common etiologies behind falls in older people, and that is cardiovascular etiologies. So some of the clues when you're taking a history from a patient who's come in to the medical take with a fall would be things like dizziness, palpitations, sudden loss of consciousness, previous cardiovascular disease, or a quick recovery after loss of consciousness. Those are all very characteristic features of cardiovascular etiology. And in terms of thinking behind why some of these things might occur, commonly we see the underlying cause being arrhythmias, which we'll talk about, valvular disease, which I'll briefly touch on, the most common versions of this, and also postural hypotension, which is quite a surprisingly complex topic, which is something that I hope to break down a little bit for you. So let's talk firstly about arrhythmias. So broadly, arrhythmias we can classify into bradyarrhythmias and tachyarrhythmias. Bradyarrhythmias, the most common ones that we see in older adults would be sinus bradycardia, pauses, and sixth sinus syndrome. In general, sinus node dysfunction is a very common thing in older adults. As the sinus node ages, there's an increased preponderance towards dysfunction, and it's not quite able to keep up the same sort of regularity as it does when people are younger. So the typical symptoms for this would be your usual lightheadedness, fatigue, or syncope. Talking then briefly about tachyarrhythmias, again, similarly, because of sinus node dysfunction, it can lead actually to manifestations such as atrial fibrillation, which is most concerning when it presents concurrently with a rapid ventricular response. And sometimes in really severe cases, it can even lead to ventricular tachycardia. Now, in terms of how we manage this, well, firstly, let's talk about actually how we diagnose these kinds of arrhythmias. So obviously, spot ECG when the person first comes in is useful because they may be in this rhythm and we may be able to capture it. However, oftentimes these rhythms are paroxysmal, i.e. they're not always present. And so we often need to do more sustained periods of monitoring. So 24-hour or even 48 or 72-hour Holter monitors, whereby the patient kind of conducts their day-to-day life, whilst we then also kind of remotely monitor and assess their heart rhythm, is quite a useful test. And similarly, if we're thinking even more sustained over a much longer period of time, we'll often use implantable loop recorders or ILR devices, which are small subcutaneous devices that just go under the clavicle on the left side typically, and are able to track any arrhythmias that occur over a much longer period of time, which is data that can then be used to guide our management strategy. Speaking of management, pacemakers generally are a very good tool that we're able to use, particularly essential if syncope is established. If it's not presenting with syncope, we can often get away with just managing the underlying condition, so things like rate or rhythm control, or considering potential offending drugs that are causing bradycardia will often be sufficient. However, as soon as it becomes significantly symptomatic, pacemakers really are our default and go-tos. Briefly then talking about valvular pathologies, as I mentioned earlier, and the most common one that you'll encounter in your clinical practice day to day is aortic stenosis. There's lots of reasons why aortic stenosis happens. All the textbooks will describe aging itself and kind of age-related calcification as being one of the more common reasons why someone might develop aortic stenosis. And as such, it's something that we see very, very commonly in this older demographic. The characteristic triad that this presents with is syncope, angina, and dyspnea. And when you listen to someone who has aortic stenosis, when you listen to the aortic valve, the murmur that you will hear is a crescendo, decrescendo, or ejection systolic murmur. This is a characteristic finding, but really what you need to do is get an echocardiogram. And the characteristic echo findings, which are things that are quite high yield for exams, are if the area across the aortic valve is less than 1 centimeter squared, or if the gradient across the valve is more than 40. So that's how we diagnose it. And in terms of management, broadly, there are 3 options. So if they're not too symptomatic and if there's a lot of other stuff going on in terms of their health, oftentimes we can get away with just conservative management, watchful waiting. But once they become syncopal, once the risk of them having falls or other kind of side effects of the valvular pathology become quite significant, we probably should be intervening. And in practice, all of these decisions go through a cardiology MDT, which will take into account the patient's comorbidities, their age, their frailty, and so on. But broadly, TAVI, or transaortic valvular implantation, is a very, very common and increasingly used strategy to manage aortic stenosis. Essentially, what this entails is, similarly to when you're doing a PCI for a heart attack, Inserting a catheter via the radial or femoral route, going into the heart, and essentially putting a balloon across the aortic valve to dilate it and hopefully improve the flow across the valve. This is quite non-invasive relative to the other options, and it's generally quite well tolerated. I've seen it myself done on patients over the age of 90, and it's been tolerated quite well. If the patient is younger or the disease is much more significant, then invasive surgery may well be a better option. And by that I mean oftentimes it's a case of replacing the valve, which will commit the patient thereafter to lifelong anticoagulation. So it's not a decision to be taken lightly, but it is often a better option. Another important topic to talk about in determining cardiovascular causes of falls is postural hypotension. Now, with postural hypotension, what is this actually defined as? Well, it's defined as a drop in the systolic blood pressure of more than 20 millimeters of mercury, or the diastolic blood pressure of more than 10 millimeters of mercury upon standing. And in order to determine this, we measure the lying and standing blood pressure at 0, 1, and 3 minutes. And if there is a sustained blood pressure drop across this time, then it's classified as postural hypotension. Now, why does this actually happen? Well, falls can occur as a result of inadequate vasoconstriction. So a really important mechanism in terms of maintaining blood pressure in body homeostasis is venous return to the heart. And oftentimes, as people get older, there is a drop-off in terms of how efficient these venous return systems are. What this results in is a lack of blood supply to the brain, so transient cerebral hypoperfusion, which manifests with syncope, dizziness, etc., which obviously increases people's risks of falls. Common causes behind this include autonomic dysfunction. So Parkinson's disease has quite a pronounced effect on the autonomic nervous system. Diabetes similarly will often have a pronounced effect on the autonomic nervous system. And also very commonly in these older patients who have lots of other comorbidities, we will often see medications contributing to this. So some antihypertensives, for example, can cause postural hypotension. In terms of how we manage this, it's quite a surprisingly tricky condition to manage in practice. We often like to start, as we saw earlier with aortic stenosis, we like to start with things being managed in a conservative fashion. So ensuring someone is well hydrated, that they're eating enough, using compression stockings or using abdominal binders, which essentially do the same thing as compression stockings, but are just bound around the abdomen to help venous return from the inferior vena cava. These can help reduce the positional drops in blood pressure. Also encouraging people to get up very slowly, to have hand supports to hand if necessary to stop them from having a fall if they do feel dizzy. These are all important things to counsel people on. Now, we do also have some pharmacological options in order to help manage things. But the most important take-home point from this slide really is the first thing you want to do in these cases is to stop or wean someone's antihypertensive medication. So oftentimes people will be on 3, 4, or even 5 antihypertensives. And whilst this may result in some improvement in their average blood pressure, we often have slightly more relaxed blood pressure targets in older people. And this is for a reason because the risks of them having significant falls, fracturing their hips, etc., is quite high and actually outweighs the benefit of achieving better blood pressure control over a long period of time. So the first step is always to see what we can reduce and to kind of see if we can reduce the antihypertensives in a stepwise fashion. Following on from this, if despite this things are not improving, we would then move on to using a couple of medications. And the first of these is fludrocortisone, which is a mineralocorticoid receptor agonist, which kind of essentially augments your blood pressure. The other option we have is something called midodrine, which is a peripheral alpha agonist. So it increases the vessel tone in the peripheral vasculature and therefore improves the venous return back into the heart. Both of these are quite effective. However, it's important to watch out for something called supine hypertension when we use these medications. What this is yes, their blood pressure will not drop as much when they stand up. However, their average blood pressure will actually be much higher lying down or sitting. And this is more common with midodrine. So it's important, therefore, to not just start someone on this medication without thinking about this first and without potentially reducing some of the other antihypertensives first. Moving on from this, there's obviously lots and lots of other causes of falls. And as I said at the start, it's always important to think about the whole constellation of a patient and not just an isolated cause for their falls. So visual impairment is the first of the neuropsychiatric causes that I'd like to highlight. So as people age, inevitably there is an increased risk of things like cataracts, age-related macular degeneration, diabetic retinopathy. These are all common presentations in older age, and it's very important when you're taking a falls history to ask someone whether they've had any visual impairments, and also, importantly, when their eyes were last checked. If they haven't had a recent eye check within the last couple of years, it's normally good practice just to encourage them to do that, because this is a very easy and very preventable way of someone having a significant fall. It's a 20-minute appointment at the optometrist versus a 20-day admission in the hospital if they have a hip fracture. Vestibular dysfunction is also quite common. So obviously the vestibular system in the inner ear is very important in terms of regulating someone's sense of balance. And the most common presentations within this category are BPPV, so that's benign paroxysmal positional vertigo, or Meniere's disease. So the way to ask about this is to ask someone if they get a sense of the room spinning around them when they're moving, particularly if they move their head quite suddenly. It's quite different to typical dizziness, which is more of a light-headed feeling. But vertigo is this characteristic spinning sensation. Now, the way in which we diagnose particularly BPPV is by doing something called the Dix-Hallpike maneuver. There's lots of good diagrams online for this, and I'd encourage you to try this on some patients because it's quite a good diagnostic test, particularly if you're on an A&E rotation. And the treatment of choice for this is something called the Epley maneuver, which again is something that you can actually teach to your patients so that they can also administer it to themselves if they are struggling a lot with their vertigo. I found in actual practice that enrolling the help of the neurophysiotherapy team is very, very useful here. So you can normally find these colleagues on the stroke ward, which is where a lot of their work is. They often deal with these sorts of presentations in and amongst the other work that they do, and are very adept at communicating how to manage these conditions to their patients. So try and get them involved if at all you can, if you have someone who's coming in with one of these conditions. Thinking more peripherally now, peripheral neuropathy is not uncommon in this older age group. This is often nutritional, so things like B12 deficiency or folate deficiency is not uncommon in all age groups, but particularly in the elderly, and can manifest with peripheral neuropathy. Similarly, diabetes, if poorly controlled over a long period of time, can also result in peripheral neuropathy. And what this means is people have less sense of what their feet are touching and therefore are less able to minimize the risk of them tripping over something and having a fall. And so obviously testing for levels of B12, folate, and someone's HbA1c is useful to do on admission. And to kind of formally assess the severity of their neuropathy, monofilament testing or EMGs, if required, are useful ways to help cinch a diagnosis and then decide what to do with this next. Going a bit further in terms of neuropsychiatric causes, obviously cognitive impairment is a very, very big topic within this age group. And there's lots of strong links in the research between vascular dementia and apraxia, or kind of having a reduction in your visuospatial acuity. And similarly between Alzheimer's disease and coordination. The whole constellation of Parkinson's plus syndrome, so Parkinson's disease, as well as things like progressive supranuclear palsy, are often associated with an increased level of motor dysfunction. So, Parkinson's presents with your characteristic rigidity, bradykinesia, and tremor, all of which can increase the risk of having falls. Depression is also something that's often under-recognized in the elderly, but is actually very, very important. Now, depression itself can cause, especially if it's very severe, can cause someone to slow down quite a lot. And its treatment, particularly SSRIs, can also contribute to an increased falls risk. There's a strong link also with incontinence and falls. And it sounds a bit silly, but something as simple as someone rushing to the toilet in the dark when they haven't had the chance to get proper footwear on, when they haven't had the chance to get their lights on or get their mobility aids, can significantly increase the risk of someone's falls. And I'm going to touch upon this a bit later when I talk about the role of the MDT. But in the first instance, managing someone's incontinence symptoms can reduce the risk of them having to rush to the toilet in the middle of the night and potentially having a fall and fracturing their hip. There's a number of drugs that are associated with an increased risk of falls, and someone's helpfully come up with the acronym FRIDS, or Falls Risk Increasing Drugs. Some of the more common examples of this include antipsychotics, antidepressants, things like TCAs and SSRIs in particular, benzodiazepines, antihypertensives, and opioids. It's believed that these medications have an adverse effect on the cardiovascular system and the CNS, and so they have an increased risk of falls as a result. And there's good level 1A or meta-analysis evidence that the use of these medications in anyone over the age of 60 is associated with an increased risk of falls. Talking a bit more about medications, this is a really important topic that I actually only learned about a couple of years ago, called the anticholinergic burden. So what actually is this? Well, it's the cumulative effect of an individual taking one or more medications with anticholinergic activity. So anticholinergic activity essentially means things like dry eyes, urinary retention, dizziness, cognitive impairment, and ultimately falls. There's a number of medications that contribute within this class, and there's a useful way to calculate this. If you just Google ACB score, you can calculate how much any one medication might contribute. And importantly, you can also just log someone's entire set of medications to see what their overall anticholinergic burden is. I tried this recently with a couple of patients, and it does often throw up some quite surprising results. So, for example, pantoprazole, which is a PPI that I'm sure we've all used at some point in treating patients with reflux or ulcers, has the same anticholinergic effect as things like steroids and morphine. And it's also important to note that someone taking a single anticholinergic burden medication with a very high score compared to a number of medications with low scores for each one, there's a high risk associated with the individual medications with a high ACV score. As the body ages, obviously someone's likely to be on more medications, and also the ability of the body to metabolize medications declines, the permeability of their blood-brain barrier increases, and therefore older patients are generally much more susceptible to the anticholinergic effect of their medications. Talking a bit more about medications, and it's important to just be aware of these criteria. There's something called the CGA toolkit, which I've just highlighted on the screen there. But generally, stop-start criteria is a useful tool to identify what medications someone doesn't actually necessarily need to be on. So what the stop criteria is it flags drugs that can cause significant harm or have a high risk of side effects. And whenever we're doing a kind of holistic assessment of all the medications someone is on when someone's just coming in, or if they're being seen in the frailty clinic, it can help identify drugs that might actually not be necessary. So things that carry a low prognostic benefit and might not be useful in someone who's a little bit older. And it helps us kind of actively promote de-prescribing practices. This and many of the medications that are listed specifically in the stop criteria are medications that increase the risk of falls. So common ones that you'll see in these criteria are things like sedatives, so benzos, anticholinergic medications, and certain antihypertensives, which carry higher risks. This always actively promotes a medication review as well, and it guides clinicians in reviewing patient medications to ensure that only the necessary and safe drugs are prescribed. Less relevant for this talk, but it's worth mentioning. In addition to the stop criteria, there's also start criteria, which kind of comes in the same domain. So this is a screening tool to alert doctors to right treatment, is what the mnemonic stands for. And this identifies medications that should be prescribed, but may often be overlooked or omitted, particularly in elderly patients. These medications are often essential for managing chronic conditions or preventing serious complications. Now, taking away the pure medicine side of things for a bit, which I know we're often as doctors or medical students very prone to just thinking about the pure medicine, but also it's important to think a bit more widely and holistically about why someone might be having a fall. And so the environmental assessment is a really important part of a falls risk assessment. And this is where we will loop in our MDT colleagues, particularly occupational and physiotherapists. So looking at things like clutter and trip hazards in someone's home is very important. Even things like poor footwear. So someone may not have particularly grippy slippers at home, and that increases the risk of them having a fall. Things like uneven flooring in the house, or obviously stairs being a big component and someone not being able to take the stairs safely. These are all really important things to think about when determining someone's risk of having another fall. Poor lighting in the house obviously will also contribute. As I mentioned earlier with the incontinence, if someone's rushing to the toilet in the middle of the night, they don't have good footwear, there's uneven flooring, and the lighting is bad, it's kind of a recipe for disaster in someone, in the sense of someone will be very high risk of having a fall. Lack of handrails and lack of non-slip mats in key areas such as bathrooms is also a very important thing to think about. And so this is really where the MDT has a big role to play. If you've ever worked on a geriatrics ward, which I hope you all will at some point in your careers, you'll often have worked with our physiotherapy and occupational therapy colleagues. And so, whilst we're optimizing people from a medical standpoint, they'll be doing a lot of work concurrently with us on an almost daily basis in terms of assessing the person's home, in terms of assessing their mobility in the hospital environment, and also in terms of seeing what sorts of progression they're going to be able to make in order to guide a safe discharge and hopefully reduce the risk of a readmission with another fall. So one thing that they can often do is setting up what's called a micro environment, which is essentially what the name suggests. So it's getting all the essential aspects of someone's daily living within one small room, or by minimizing the number of rooms across which everything is spread. And so it minimizes the amount of distance that someone has to travel, and this therefore reduces the risk of falls. Going beyond just the hospital workers, so beyond the OTs and the PTs, social workers are often also very important. So they can connect patients to community services to help with home modifications. Let's say someone needs to get a ramp installed in the house. This is a useful way to enable that to happen. Or they can recommend placement if the falls risk is deemed too high, or if the housing needs to be changed for a new, more suitable house. There's also a big role of the patient's family in terms of reducing falls risk. So oftentimes, the therapists will involve families and give education to family members, because they will help essentially guide someone's family in terms of tools that they can use, strategies that they can use to reduce the risk of falls, and so on. So that's been a general overview thus far in terms of how we reduce falls risk and how we identify key risk factors in terms of someone coming in with a fall. If anyone has any questions at all, please do flag them in the YouTube chat. I'll answer them either as we go along or at the end, but please feel free to just type anything into there. And as I said earlier, if you wait till the end, I will be giving out a link for a feedback form, which will also get you a certificate for your attendance for your teaching logs. So now I'm going to talk about conducting a falls assessment. So the way I like to think about this whenever I see a patient with a fall is before, during, and after. So let's start with the before. So ask about what the patient was doing, where they were, what they did differently on this day, and how they felt immediately before the fall. Some specific questions to ask for when we're thinking about our causes of falls are things like feeling dizzy, having had any chest pain, any vertigo, and remember, ask specifically about if the room was spinning or if they lost consciousness. Then talking about during the fall, so ask about how they actually fell. So what height they fell from. Did they break the fall with anything? Let's say, did they put out their hand to try and stem the fall? Did they hit something like a chair or a mattress or a bed frame first? And which parts of the body did they fall onto? It's important to do a systematic screen to make sure that they didn't hurt any other parts of their body other than, say, their hip, which will often be the more severe injury. And then thinking about the after. So how long was the patient on the floor for? How did they get up? And did they have any further falls? Was there anything in the presentation that suggests that they may have had a seizure? So being post-ictal, so having had any incontinence, tongue biting, or being generally drowsy after having the fall are all clues into this potentially. Beyond that, it's important to inquire about someone's general health in the days leading up to the fall, and inquiring as to their past medical history. Have they had falls previously? What was the circumstances of these falls? Do they have any diagnoses that were made as a result of them? And what other medical conditions might they have that will increase the risk of falls? Talking a bit more in depth, so key risk factors that we should always be assessing for are comorbidities, and let's talk briefly about this. So assess the patient's cardiovascular health first of all. Conditions like heart failure, arrhythmias, or hypotension can all impair circulation and lead to dizziness or syncope, which increases falls risk. Check for other conditions in a more neurological sense, such as stroke or Parkinson's disease, which will have obvious effects on motor control and balance. And from a musculoskeletal standpoint, ask about things like osteoporosis, bone density, long-term steroid use, which can all increase the risk of fractures if someone has had a fall. From a cognitive status, dementia or even acute delirium can affect balance or gait, and obviously they can lead to confusion, all of which increases the risk of falls. Ask about someone's baseline mobility. So ask about whether they use any mobility aids when they're normally at home. Sometimes people will be using mobility aids only when they leave the house, but they won't use anything within the house. Are they using things like a cane in the house or a walker outside of the house? And how often do they require these tools? Because often this will help guide us as to whether these mobility aids or a lack of adequate mobility support may have contributed to their fall. Ask about if the patient has a care package, and if they do, how often do they have someone come in? If the patient and if they do have a care package, ask about what exactly the people do. Do they need help getting out of the bed or going to the bathroom, or is it just a case of them needing someone to go out with them to have a walk or to help them with the cooking and the cleaning? Lack of adequate support or kind of a lack of an adequate care package obviously increases the risk of falls, and it's important to characterize what their baseline is in this sense. Do a detailed medication history. We talked obviously earlier about the anticholinergic burden, and I'm just going to highlight this again. Lots of common medications, things like antihistamines, antipsychotics, and certain antidepressants will increase the risk of someone having a fall. And they carry anticholinergic effects, which can impair cognitive function, leading to confusion, dizziness, and falls. Ask them about their antihypertensive medications, because these can obviously cause postural hypotension, as we talked about earlier. And ask about the long-term use of steroids, because what this will do is it will weaken someone's muscles and bones due to osteoporosis and myopathy. And this will affect their bone density and increase their susceptibility to fractures. Moving on to examination, which obviously is a very important part of admitting someone into the hospital. So when you're doing your cardiovascular examination, get an ECG, feel their radial pulse, see if they're in AF, because this gives us some clues. Listen for any murmurs. So aortic stenosis, obviously, we talked about in some detail earlier. Mitral regurgitation is also a systolic murmur, but it's a pan-systolic murmur, and it carries a very high association with atrial fibrillation. So it's useful to pick it up and document this if you do find it, because it might help manage someone in the long term. Get a lying standing blood pressure. You might need to ask your nursing or therapy colleagues to help with this, because it may involve getting the patient to stand up with support. But it's important to do this at 0, 1, and 3 minutes. And again, you're looking for a drop of a systolic of more than 20 or diastolic of more than 10 at these time intervals. Perform a neurological examination tailored to your history. So assess if you're suspecting vertigo, potentially incorporate the Dix-Hallpike maneuver in to assess for labyrinthine symptoms. And it's always good at the baseline to get what's called the 4AT score, which I'm going to highlight on the next slide. But this is a very useful test for delirium and has been found independently to predict immobility, length of stay in the hospital, and in-hospital mortality. So it's a really useful tool to capture, because it will help guide the severity likelihood of the rest of the admission. Now, someone who is old and vulnerable is obviously much more susceptible to fractures. And so it's very important to do a comprehensive musculoskeletal examination. Now, normally our A&E colleagues are very good at doing this and excluding fractures before the point of referring to the medical team. However, it's often good practice just to double check. So the big things to never miss are a neck of femur fracture. So this is a hip fracture, and characteristically this will present with the affected limb being shortened and externally rotated, but that's not always the case. It's also important to assess for other potential fractures, things like a radial fracture, so Colles, or a humeral fracture. And as I said, this is normally done very well by A&E before referral. Most A&Es and most patients who present with high risk falls to A&E will have had what's called a silver trauma scan. So this is a focused CT scan of the chest and the abdomen and the hips and the spine, essentially to make sure that someone has not had a fracture. So it's focused specifically on trauma. Talking just a little bit more about the 4AT score. So here it's quite a simple test. So you assess how alert someone is. You ask them to recite their age, date of birth, name of the hospital or building that they're in, and what year we're in. And then you instruct the patient to list the months in reverse order. And lastly, you try and ascertain whether this is an acute change or a fluctuating course. And this gives you a total score. And this is, as I mentioned earlier, strongly linked to post-operative outcomes if someone has had a neck of femur fracture and in terms of determining their long-term survival. So it's a very useful tool to pick up at the point of admission. What are the initial investigations that we're going to do beyond our clinical exam and history taking and our CT scan at the front door? Well, blood tests, obviously, which I'm sure would have already been started before the patient has been referred to the medical team. But getting a full blood count to look for anemia, obviously anemia can increase the risk of falls. Looking for clues as to B12 or iron deficiency, so mastocytosis or macrocytosis is useful. Looking for inflammatory markers, so if someone's got a raging pneumonia, they're often more likely to be delirious, and this increases the risk of falls. Looking at electrolytes, so things like hypocalcemia, hyperkalemia can all increase the risk of cardiac arrhythmias and therefore increase the risk of falls. And B12, folate, and hypothyroidism can all increase the risk of confusion as well. So it's important to screen for these things if there's any suggestion that delirium may be a contributing factor to someone's fall. And also, it's very important to send a vitamin D level off at the front door for reasons I'm going to highlight shortly, which relate to bone health. We've mentioned, obviously, imaging. So the silver trauma pan CT, a CT head, firstly to exclude any evidence of acute trauma, but also to look for evidence of chronic cognitive impairment. And I'll show you an image in a second of what that might look like. And if you're suspecting infection, get a chest x-ray to assess for any evidence of infection. So a couple of x-rays. I'm by no means an expert nor an orthopedic surgeon. However, I hope you can appreciate here that the left hip is significantly abnormal compared to the right hip. Now, remember when I'm looking at x-rays, everything is inverted. So as you look at your screen now, the left hip of the patient is on the right of your screen. And you can see here that there's a red line, which, if you look at the other side, is a continuous line in white. That's called Shenton's line. So on the left side of the patient, we can see that there's a disruption in Shenton's line. And you can see that the head of the femur is in the right place, but the neck and the shaft of the femur are significantly displaced. And so this is a displaced neck of femur fracture. And this is something that is a surgical emergency that needs referral to the surgical team. Normally, they like to operate within 24 to 48 hours on these, if at all possible, because that carries substantial mortality benefits. This CT head I've just included here just to highlight what a typical brain of someone who has chronic cognitive impairment may look like. So normally the brain is a lot more full in the sense of, if you kind of see what I'm saying, there's less negative space. So all the darker spaces within the intracranial cavity there are essentially shrunken brain. So prominent ventricles in the middle and prominent cerebral sulci on the sides. This is all consistent with the picture of cerebral atrophy, and it's a very common CT scan to see in chronic cognitive impairment. So moving beyond imaging and moving beyond the initial clerking, if someone is coming in with what looks like a cardiac cause for their fall, it's important to get an echo. And what we'll see in the echo is if there's any evidence of valve dysfunction, so aortic stenosis, mitral regurgitation, which is particularly associated with atrial fibrillation, and to look for any evidence of left ventricular dysfunction, so to essentially assess for heart failure. Get an ECG on admission and make sure that if there's a suspicion of arrhythmias, that someone is booked in for a Holter monitor. If it was a severe fall, it's ideal to have this as an inpatient, but it can be done as an outpatient as well. And given that you're now an expert in terms of taking a falls history and you've done a really good job with your drugs history, if you're suspecting an iatrogenic cause or a drug-related cause for the fall, think about taking some drug levels. So digoxin is something that people are often on for AF. It's got a very narrow therapeutic window. If someone's got something like an acute kidney injury, then they're likely to be outside of this window. And so it's very important to manage the kind of the therapeutic levels that we're at and take a digoxin level. And again, just highlighting the importance of the stop and start criteria. Thinking a little bit longer term now, bone density is something that's very important, because if someone has a much lower bone density, then there's an increased risk of having sustained a severe fracture. So oftentimes you'll see someone and you've asked them, let's say it's an 85-year-old person who's come into A&E, they've had a fall from the edge of their bed, which in younger people who are otherwise healthy probably would maybe give them a bit of a bruise, but it wouldn't cause a severe fracture. However, this poor person has come in with a displaced neck of femur fracture. Now, why has this happened? Well, it's likely because their bone density is much lower than their younger counterparts. And so there's lots of ways in which we assess this, but the DEXA is the kind of gold standard. So what actually is DEXA? So it's an X-ray modality. So it uses two different intensities of X-ray, which are absorbed in different amounts by bone and soft tissue. And so the machine that calculates this, it uses some very clever algorithms to essentially determine bone mineral density by determining how much of the differing X-ray beams is absorbed by bone in terms of grams of mineral per square centimeter. This can then give us something called a T-score, or if it's a younger patient, a Z-score. And this is based off data collected over thousands of patients over a long period of time. And a normal bone density, this is useful for exams, is a score of more than -1. If it's less than -1 to -2.5, someone is osteopenic. And if they're less than -2.5, then this is clinically osteoporosis. This can also then be combined with something called the FRAX score, which incorporates a few other things like age, sex, BMI, smoking, alcohol use, and prior fractures, and also steroid use. So steroids, if someone's using more than 7.5 milligrams of prednisolone for a sustained period, this increases the risk of fracture. And so the FRAX tool gives us a 10-year probability of a major osteoporotic fracture. And if someone is already receiving treatment for reduced bone density, so bisphosphonates, which I'm going to come on to shortly, then they should have these DEXA scans every 2 years when they're on treatment. So what can we do to reduce the risk of someone sustaining a fracture in terms of bone density? Well, the first thing just to highlight is the importance of vitamin D. So vitamin D is very important in terms of facilitating calcium absorption. Calcium, as we know, is essential for bone health. So all patients who come in with a fall should have a vitamin D done on admission. Just apologies for this. I'm just going to go over the physiology of vitamin D very quickly. There are 2 stages of vitamin D activation. Firstly, in the liver, it's converted, this is the first hydroxylation, so it's converted to 25 hydroxyvitamin D. And then it's converted to 125 hydroxyvitamin D in the kidneys in the second stage. And so if someone has CKD, there's going to be an impact in terms of vitamin D activation. When vitamin D is active, it stimulates calcium absorption across the intestinal plasma membrane pumps, particularly in the duodenum and the ileum. And what levels are we actually targeting? Well, someone is considered vitamin D deficient if their levels in the blood are less than 25 nanomoles per liter. They're insufficient if the level is between 25 to 50 nanomoles per liter, and they're replete or there's sufficient levels if it's more than 50. If someone is vitamin D deplete, the guidelines will vary in terms of how we replace this from hospital to hospital. But in my current hospital, if the level is less than 50, we give them 125,000 international units loading on day 1, followed by 7 days of 25,000 international units. And then we put them on a maintenance regimen of AdCal-BD. If they're above 50 in terms of their vitamin D level already, then we just give them their maintenance level to begin with. And it's very important to do this before we give bisphosphonates, because there's a consumptive effect in terms of calcium when you give someone bisphosphonates, and so they can become severely hypocalcemic. So what do bisphosphonates actually do? Well, they work by inhibiting the osteoclasts. These are the cells which break down bone, and so they preserve bone structure and reduce turnover. Increasingly, we use IV options rather than oral options. So historically, we've used oral bisphosphonates like alendronate, but these are very impractical. You need to take them first thing in the morning on an empty stomach with a full glass of water. You need to then have someone stay upright and avoid eating or drinking anything else for at least 30 minutes to prevent any irritation to the esophagus. And so this is really challenging in older patients who will often struggle to sit up for that long, have other conditions like reflux, and it's challenging for someone to maintain. So therefore, we now have IV options. So zoledronic acid is a great example of this. It's a once yearly option. There's no need to worry about any of these factors in terms of taking it regularly. But it's important to counsel someone on how we use bisphosphonates, specifically that they might feel a bit unwell immediately afterwards. So flu symptoms after the infusion are not common. Someone can become hypocalcemic and vitamin D replaced beforehand. And there's an increased risk of atypical femoral fractures, as well as osteonecrosis of the jaw. You also can't give it to people when they have an EGFR of less than 35. And so it's important to make sure that someone is not in CKD beyond that point before giving it to them, because it won't work and it will cause more harm than good. So it's not always an option, but we do have lots of other options. These are just a few that I'm highlighting here. So denosumab is a rank ligand inhibitor, which you give every 6 months, and this is often useful for people who can't take oral bisphosphonates. Teriparatide is a PTH analog, which stimulates bone formation, and this is useful for essentially when bisphosphonates have failed. It's something that's used as a backup option. Raloxifene is a selective estrogen receptor modulator, which mimics the effects of estrogen on bone, and it's particularly useful for postmenopausal women who are at risk for osteoporosis. And it also reduces the breast cancer risk, so it carries that added benefit. And strontium will inhibit bone resorption and stimulate bone formation, but this has a lot of cardiac side effects. And so these are not first-line options because they all have quite significant side effect profiles. But really, and this is now coming towards the end of the talk, I think I really just want to highlight the importance of prevention as treatment. So the British Geriatrics Society consensus guidelines from last year, they advocate for opportunistic case findings. So they specifically say that clinicians should routinely ask about falls in their interactions with older adults, or even if they've had near misses. They should be asked routinely if they've experienced one or more falls in the last 12 months, and about the frequency, characteristics, severity, and consequences of any falls. This can help us then put in place falls prevention programs, which are designed to address potential barriers like low self-efficacy and a fear of falling in the patient. And they aim to negotiate and encourage changes to patients' activity levels to hopefully reduce the risk of this happening. We can often also implement structured exercise programs, which are very useful in terms of reducing the falls risk. And so now just coming to the conclusion slide, after which I'm just going to pop up the feedback QR code. Falls are likely to be an increasing cause of morbidity and mortality in the elderly. And so it's a really important thing that you're all going to see when you're on medical take and when you're clerking in your patients. It's easy to think about them as being very straightforward and easy, but they're often actually quite nuanced, complex, and multifactorial. And so you really need to do a thorough systematic assessment, which I've hopefully talked you through today, to establish the cause for this. The treatment of falls and prevention of falls both rely heavily on the wider involvement of the MDT. And so it's important to understand the role of physiotherapists, occupational therapists, social services, and so on, as well as our wider colleagues in general practice and beyond, in terms of reducing the risk of falls going forward. And that's just some references. And here is the promised QR code for the feedback. You just need to put in the name of the talk. So just put in Geriatrics Series Fractures, and this will then get you your certificate, and it will also give us some useful feedback for us to decide how we're going to run the rest of the series. Please feel free to ask any questions in the YouTube chat. Thank you very much for attending and for sticking through the presentation, and hopefully it's been useful, and hopefully you'll be able to attend the rest of our series as well. I will leave this up and I will leave the chat open for a few minutes just in case anyone has any questions. But thank you very much. Thanks, Sweta, for the comment. Yeah, no, that's fair enough. I guess it's often difficult to manage things in terms of if you don't have all the resources available to you. I mean, a very comprehensive history is always useful in terms of, as I said earlier, looking at exactly how someone has had a fall, which parts of the body they've hit, and doing a very comprehensive assessment of the bone itself. You know, oftentimes when people talk about things like hip fractures, like I said, shortened and externally rotated is how we often see this, or with a Colles fracture, we'll see a dinner fork deformity in the radius. But it's a little bit challenging in the absence of definitive imaging to rule out a fracture. I think really also, you know, let's say someone has a fracture and they do need surgery to fix this, they will at some point need some sort of imaging in order to guide how this is going to be fixed. So I think if you have a very high suspicion of a fracture, it would be a good idea to just kind of clearly highlight this to the patient and encourage them to go to wherever their kind of appropriate imaging facility is. Obviously, I'm working in the UK, so I don't have a full grasp of exactly how things go elsewhere. But generally, if you're suspecting a fracture, it's worthwhile getting some imaging. But thanks for the interesting point. No worries. Okay, I'm going to call it there. Thank you so much to everyone who attended, and I look forward to having you at the next talk.